Welcome, everybody. I'm sorry for the delay. We had a couple of technical difficulties in getting logged in today. I'm Mark Mather. I'm Associate Vice President with the Population Reference Bureau. I want to thank you for joining us today for this webinar on Global Family Planning Goals and Measurement. Where are we now? Today's webinar is co-sponsored by PRB's Center for Public Information on Population Research, that's CPIPR, and the Hopkins Population Center. I want to thank Emily Agree, who's Associate Director at the Hopkins Population Center, for helping us put this together. PRB and the Hopkins Population Center, we used to organize an annual symposium, and this is the first year that we are switching to a webinar format in the interest of reaching a broader audience. Please visit the CPIPR website if you're interested in viewing our previous events, all of which are recorded and archived. Today's event is funded by the Eunice Kennedy Shriver National Institute of Child Health and Human Development. Just a couple of housekeeping notes before we get started. If you have any questions you'd like to submit to the presenters, you can type it into the question box in your webinar control panel. That's the panel on the right-hand side of your screen there. And if you type that in, we do have quite a few people on the call today, so we will try to get all of your questions answered, but if not, I'm sure that the panelists would be happy to answer them after the presentation. There's also going to be a very short survey at the end of this call, so please take time to fill that out. It will help us plan for future webinars. This webinar is being recorded, so if you need to leave early, you'll be able to access it online later. We'll send you a follow-up email with a link to that recording. At this point, I'd like to turn it over to Susan Rich, who's Vice President of International Programs at PRB, who's going to provide some introductory remarks about today's presentation.
Thank you. At PRB, we recognize that family planning contributes to healthier children and mothers, but more than 200 million women worldwide have an unmet need for modern contraceptives. 2 years ago at the London Summit on Family Planning, leaders of 150 countries and international organizations embraced the significant goal of expanding access to family planning information and services to an additional 120 million women by the year 2020. But there are significant obstacles to realizing this dream or this goal, and one is we have a lack of reliable monitoring and data collection mechanisms. We desperately need better data, and monitoring is critical to hold donors, governments, and service providers accountable. Today in this webinar, Scott Radloff, who's a senior scientist at the Bill and Melinda Gates Institute for Population and Reproductive Health, and Emily Sonneveldt, who's director for the Center of Monitoring and Evaluation and Advocacy at the Futures Institute, will tell us about how mobile technology is being used by local data collectors in Africa and Asia to generate rapid turnaround data, and how this information is being used in tandem with modeling that leverages service statistics. Let me start out by introducing Scott Radloff, Senior Scientist at Bill and Melinda Gates Institute.
Okay, great. Thanks, Susan. I hope you can see my slides, everyone. Welcome, everyone, to the webinar. As Susan mentioned, I'm the director of PMA 2020, which is one of two projects that were designed jointly with support from the Gates Foundation and launched just a little over a year ago. So I'm going to spend the next 20 minutes or so talking about PMA 2020. PMA 2020 came about through the confluence of two streams. One is the need for more frequent data to mark progress against the goals and principles of FP 2020. And the second is the evolution of smartphone technology. So smartphones today are like a computer in your pocket. They have large memory to be able to save a lot of information, and they have various applications, apps, that have been developed to make the smartphone useful for a variety of functions. And the one that we're interested in is an app that's called ODK, Open Data Kit, that allows you to construct questionnaires, to administer interviews, and to collect and aggregate data. So it's the evolution of the smartphone and also the wider reach that cell phones have in countries throughout the world. So this is a project that wouldn't have been possible 10 years ago or even 5 years ago, but the technology has advanced to a point where this becomes a possibility to use cell phones as a way to gather data and to report information on a close to a real-time basis. So the objectives of PMA 2020 is to monitor progress against the goals and principles of FP 2020, to establish rapid data collection and produce annual and actually semi-annual estimates initially. It establishes an information feedback loop for national, regional, and community action, and it builds sustainable country capacity for continuous monitoring. We have 10 countries planned at the moment for the survey. 5 are already underway: Ethiopia, DR Congo, Ghana, Kenya, Uganda, and you can see 5 more countries planned for year 2. It involves 2 linked mobile-assisted sentinel surveys. One is a household and female survey to measure demand and use, and the second is a facility survey measuring supply and access. Various features of this survey, of course, it uses this innovative mobile technology that I described. It produces annual, and for the first 2 years of every country, we're going to be collecting data semi-annually on a battery of indicators. It provides consistency with DHS measures. About 90% of our questions are direct replicas of DHS, so we have that comparability. But it also introduces a new set of indicators of quality, choice, and access. It creates a community feedback loop to prompt program improvements. And once the platform is established, it's expandable to other health sectors. Initially, it's focused on family planning and a few questions on water and sanitation. And last but not least, it involves strengthening local capacity. We're working through a network of partner universities and research institutions, many of which have been collaborating partners with the Gates Institute. And then also, importantly, we're creating a network of resident enumerators, resident female enumerators who are recruited from the enumeration areas that they will be surveying. So how does this work? So we start with enumeration areas, and to give an example, in the case of Ghana, we have selected 100 enumeration areas from across the country. So it's representative of the country of Ghana. And for each enumeration area, as I mentioned, we recruit a female resident enumerator. So she either lives in that enumeration area or close by. It's a woman, hopefully, we found that women in their 20s or maybe their 30s are better able to learn this technology than older women. So we recruit these women, and we train them in using the mobile smartphone. You can see ODK is loaded up onto the phone. And she is charged with conducting interviews across 42 households in her enumeration area. And these are households that are randomly selected. Plus she conducts a survey of up to 3 private service delivery points. And her supervisor is responsible for collecting data on public sector service delivery points. And there we look for the nearest health post, the nearest health center, and the nearest referral hospital. Once she conducts the interview and completes the questionnaire on her smartphone, she takes a GPS reading and then submits it through a GPRS network, through the phone network, to a central server for instantaneous data aggregation. It allows us to manage the data so we can see the data in real time as it's coming in. We can validate the data. We can identify any problems with the data collection and correct it as we're implementing the survey. We hope to implement the survey in a 4 to 6 week period. Once the last enumerator submits the last questionnaire, we have a complete data set, and we can generate reports, tables, graphs, and maps, as you can see here. We can share them with community and other regional and national stakeholders, and also feed information back to the enumerator to these communities. So there are many advantages to using mobile technology as opposed to paper and pencil surveys. We speed data collection, and we reduce data errors. There's only one step for entering the data electronically rather than 2 steps. Also, ODK allows us to introduce automatic constraints, so we can't enter in invalid data. It has skip logic, so we don't skip important questions and we skip over unnecessary questions. And this all results in more rapid reporting and tabulation of the data and feedback to communities. I just wanted to show a few of the screenshots of ODK questions on our phone. The first example has to do with education, and you can see there are radio buttons there. It's set up in a way that you can't advance to the next question unless you answer this question, and only one answer can be selected before you move forward. The next one gives you an example of a numeric response. This is how old were you when you first used a method of contraception, and this has constraints built into it, so you can't enter an age like 5, or you can't enter an age that's older than you are now. The third screenshot shows you assets in the household from the household survey: electricity, wall clock, a radio. So these are a battery of assets that are used to calculate the asset index, the wealth quintiles that everyone is familiar with. You can see the scroll bar on the right that shows you that there are more assets to be recorded in additional screens. They don't fit all on one screen in this case. And then the last one is a question from the service delivery point survey, which asks what methods are provided. Counseled on, provided, prescribed, and charged. And there are check boxes for each of those. And again, you can see the scroll bar. We can see just the first 2 methods there. There are 14 in all. Because we're using cell phones, it lends itself to other types of data collection. So we have a cell phone that can collect GPS coordinates, which are useful for us to be able to go back to validate data or complete incomplete data collection. There's a date and stop timestamp, so we know when interviews started and completed, and thereby we can identify enumerators that are taking too long to complete the survey, which could be an indication that they need further training. We use the photo facility to record the entryway to households and facilities that we interview. Again, a way to be able to go back to validate data collection. And then finally, barcoding. This is something we haven't used to date, but something that could be used in the future as a way of identifying what types of commodities are available at service delivery points. And then payment for resident enumerators. In Kenya, there's mobile phones are used widely as a way of purchasing and sending money through something called M-Pesa. So in Kenya, we're going to be using this as a way to pay our enumerators. So once they complete their survey quotas, they can be paid instantaneously. So here's the status of our surveys across the 10 countries that I mentioned at the outset. Ghana, we've completed 1 round, and we've just recently completed the 2nd round of the survey in Ghana. DR Congo, we have round 1 complete and are about to start round 2. Ethiopia, round 1 is completed. You can see the various institutions that we're working with, mostly universities. Uganda and Kenya data collection is underway. We hope to have that completed next month. Training to begin next month in both Burkina Faso and in Nigeria. And Indonesia, India, and Niger are yet to come. So I mentioned that we have measures of access, equity, quality, and choice. These are just some examples from the female survey. We have 51 questions, 31 around family planning. All these indicators can be disaggregated by age, marital status, wealth quintile, education, region, urban and rural. For current users, we ask on your most recent visit, did you obtain the method you wanted? If not, why not? Who made the final decision on the method you received? I won't read through all of these. For discontinued users, what was your method? And when did you stop using? And why did you stop using? And then for women with an unmet need, the reason for not using a method. For our service delivery point, we also have measures of access, equity, quality, and choice. For service accessibility, we ask how many days a week is family planning offered? Are they offered today? What methods are counseled, provided, referred, and charged? That was on the screenshot that I showed you earlier. If we skip down to service quality, does the facility have a system for client feedback? And we ask to see it. And has there been any change as a result? On integrated services, if delivery or maternity services are offered, we ask if family planning is counseled during the postpartum visit and are services offered or referred. We do all this also for facilities that provide post-abortion care and HIV-related services. So a few top-line observations from having conducted now completed 3 countries. It's clear that these resident enumerators are the backbone of PMA 2020. We're successful only so far as they're successful in conducting their work. So we need to recruit well, train well, support, reward, retain enumerators. We've also learned no phones, no program. We borrowed that concept from JSI on commodities, but it's true that it's not so easy as it seems to get the right phones in the right place at the right time. For starters, there are very few smartphones that meet our criteria. Many of them fail on GPS accuracy. And then finally, there's been strong government interest in the survey in general, but also interest in getting subnational detail and additional modules. But we want to build the platform first. We don't want to build it too big. We want to prove the concept before we start expanding. So what are we learning? We've learned that these resident enumerators can be trained to conduct mobile-assisted surveys. Survey rounds can be completed in a 4 to 6 week period. We employ something called cascade training, where we at Johns Hopkins here train the supervisors, and they in turn take responsibility for training resident enumerators. ODKs performed well. I'm not going to go through all of these, but more front-end training than we envisioned, just one of the surprises. A greater number of supervisors required than we first estimated. And we're still learning about how resilient this enumerated network can be. So we produce a family planning key indicators report, which you see here for Ethiopia. And this is a 2-pager that contains all of the high-level indicators for FP 2020, which we feed into Track20, which Emily will talk about momentarily. And then this is supplemented by a detailed indicator report, which takes these and other indicators that we collect data on and break them out by age, marital status, region, wealth quintile, education, etc. And this winds up being about a over 100-page report. So I just wanted to present a few results from Ghana, round 1. And I'm trying to go through these fairly quickly. So the first 5 bars you see here are the 20 years of data collection from the DHS, and you can see that modern contraceptive prevalence among married women has increased fairly consistently. You can see a little drop in 2008, and we've, in our 2013 PMA 2020 survey, we've recorded a rebound to 18.4% modern use. And this shows you the method mix of contraceptives in Ghana. And you can see that the injectables is the largest, most widely used method, followed by pills and implants. And I don't have the DHS from 2008 here, but I can tell you that 3 methods have grown in this method share. First of all, implants were measured at 5% in the DHS. It's grown to 16%, so quite an increase in implant use. Injectable use has increased from 38 to 41%, and pills have increased from 26 to 29. And we're also showing a decline in the share of users of condoms, sterilization, and a slight decrease in pill use. Here's unmet need for family planning, and really not a lot of change from the DHS, a slight increase, but also with the increased contraceptive use, we have higher demand satisfied with a modern method. So 28% of the demand was satisfied in 2008, 33% we're measuring today. This is current use, modern method use in the purple part of this bar, and unmet need at the top in blue. And what's interesting about this, we show this across the wealth quintiles, the poorest being the bar chart, the bar graph on the left, and the right Q5 is the wealthiest quintile. And what's interesting about this is there really isn't a whole lot of variation across the quintiles. There's fairly consistent contraceptive use and fairly similar levels of unmet need. At the top of the bar, you see the percent of demand satisfied of the modern method, and this varies from 30% to 36% across the quintiles. So this is unusual, I would say, for most of Africa. Usually you see a much larger differential, much higher use among the wealthiest and much higher unmet need among the poorest quintiles. Here are fertility indicators, and we're recording a decline in fertility from the 2008 from 4 to 3.7. You can see the adolescent birth rate, just a slight decline. The recent births unintended has actually gone up. And here you do see a differential between the poorest and the wealthiest. So among the poorest quintile, 44% of the most recent births were unintended. As for the poorest quintile, and just 21% among the wealthiest. This shows you the long-term fertility decline going back to 1988. You see it going from 6.4 to 3.7 today. Here are some indicators of access, equity, quality, and choice. So 94% of the women on their last visit obtained the method of choice, and we can break that out to find out why the 6% did not obtain that method. Whether the method was chosen by the woman herself or jointly with a provider or partner, 90%. 66% had paid for services. Just 57% were told of other methods and counseled. About 50% counseled on side effects, and if counseled, told what to do with side effects, 78%. 100% of sterilized users were told that the method was permanent. Of course, the very small N there, only 10 women using sterilization in our survey. And then 70% would return to the provider or refer a friend or a family member. I'm going to skip past this one here just in the interest of time because I think I'm going a little bit over time, but you can see the percents of who decided themselves or jointly or whose decision was made by the provider or partner. Now this is an interesting graphic. This shows again the lowest through the highest wealth quintiles, and this shows the percent who paid for their family planning services. And this goes in the opposite direction that you would hope for. If you're wealthier, you're more likely not to have to pay for your services. And one thing that I should point out is that Ghana is has just recently launched a national insurance scheme, and in family planning and contraceptive services are to be covered by that scheme. So over time, we're going to be able to figure out how that scheme is impacting on payment for services. So this breaks out how many are satisfied with their services. That is 80% who would return themselves, 78% would refer a relative or friend, and 70% would do both. This is the percent of women receiving information from a provider in the past 12 months, either being visited at home or being told about family planning at the health facility. And this is interesting that it's more likely to happen among the poorest quintile. So this runs in the direction I guess you would hope to see, that the poorest women are finding information on family planning. We're getting a service delivery point questions. I just have a couple more slides if you'll bear with me. Percent offering family planning services, 96% of public facilities and 70% of private. More likely that the public sector is open 5 days a week. And you can see the offering of different methods. So both public and private have a high percentage offering condoms and pills, but then you see the decline among the private facilities offering the longer acting methods. This is the percent providing counseling and services to adolescents. It shows 100% in the public. That may be more policy than practice, perhaps. 89% in private. Whether the facility had mobile outreach support in the last 12 months, you can see 31% of public facilities reporting that support. Charging fees for services, more likely in the public sector than private, which is interesting. Having a client feedback system, very high, 100% in public sector. And then integration of services, and you can see that's fairly high in the public sector, 90%, 87, 91% in the different service integration areas, lower percentages in private. This is our stockout indicator, and interestingly, the highest stocked-out methods are the pills and condoms. The most popular methods shown before were injectables and implants, and those are lower levels of stockouts. And this is my last slide. And this just shows you modern contraceptive use on the left by region of Nigeria, with the darker ones being the higher prevalence, and on the right side, unmet need, again with the darker being the higher unmet need. And these are almost mirror images of each other. So where contraceptive use is high, unmet need tends to be lower, and vice versa. So I'll stop there. We have some links to our website and Facebook and Twitter accounts, so please check in on those. And let me turn it back to Mark or to Susan or Emily. Thank you.
Thank you, Scott, for sharing not only the new technology but also the rich data that you just presented. I'm sure we'll get questions at the end. At this point, I'd like to turn it over to Emily Sonneveldt, who will talk about Track20. This is seen as a sister project to PMA 2020 that you just heard about. And Emily is the director of the Center of Monitoring and Evaluation and Advocacy at the Futures Institute. Emily?
Thank you, Susan, and thank you, Scott. So my presentation today is going to introduce a new model developed by the Track20 project, which allows for annual estimation of some key family planning indicators. So the Track20 project is responsible for providing annual monitoring towards the global FP 2020 objective of 120 million additional modern method users by 2020. And this includes providing annual estimates for the 15 FP 2020 core indicators for all 70 countries. So when we were developing Track20, we had a few guiding principles that informed how the project was going to be able to provide these annual estimates. The first one was that we would focus on finding ways to use existing data. Specifically, we would not create new data collection mechanisms. So this is in contrast to PMA 2020, which Scott just talked about. And the second one, that our efforts would strengthen national level family planning monitoring efforts and put in place a process where annual estimates are actually being produced by the countries themselves. So one very big caveat to this second principle is that this process is only being supported in 23 of the 70 countries. And these countries are listed at the bottom of the slide. Okay, so the big caveat is that second guiding principle, the one that we would be involved directly with governments to enforce their capacity for family planning monitoring, is only actually happening in 23 of the 70 countries. And you can see those countries listed at the bottom of the slide. So these are countries that represent the 22 countries that pledged a commitment to FP 2020 during the July 2012 summit in London, plus the DRC. So although Track20 will report annual estimates for all 70 countries, the direct support to governments is only currently planned for these 23 countries. Next slide. So with those principles in mind, we developed a project that intends to transform the current system, which, as you all know, relies heavily on large national surveys that happen about every 5 years, to a system that produces annual estimates through the application of new tools, models, and estimation methodologies that expand the usage of existing country-produced data. Specifically, we're focusing our efforts on expanding the role of service statistics. So Track20 is implementing a suite of activities in these 23 countries, including providing family planning dedicated M&E officers, providing them with capacity building and ongoing trainings, instituting a process where governments hold annual meetings to review family planning data and to come to agreement on progress made in the family planning program, and providing support for countries to use available family planning data for informed decision making. And then, most important for this presentation, and what I will focus on for the rest of my talk, is the development of new models and methodologies. So next slide, slide 4. So before we get into how we will use service statistics, let's just take a minute to make sure we all have a common understanding of what I mean when I say service statistics. So we are focusing our efforts on the 3 types of data listed here. So the first is commodities that are distributed to clients. So this is usually found in LMIS or Logistic Management Information Systems. The number of contraceptive users, which some countries record these as new acceptors and continuing users, others put them all together. And this information usually comes from HMIS or Health Management Information Systems. And the third one, a number of clients or number of visits, which is recorded disaggregated by family planning method, which is also available through the HMIS data. So next slide. So there are both advantages and disadvantages of using service statistics. So the advantages are that the data is available frequently in pretty much all countries, and it's definitely available annually, and in some cases as often as quarterly. There's a high level of geographic detail, so since the numbers are collected from the bottom up and aggregated at different levels, it's often possible to have this data by facility, which is important if they're collecting data from community-based distribution, at the district, at the regional or provincial level, and at the national level. But there are also some pretty significant disadvantages. The chief among them, which is well known, are the data quality issues with service statistics. The data is often incomplete because not all facilities or districts or regions submit their data. There's also bias and error due to the difficulties in recording new and repeat users, and the possibility of clients visiting more than one distribution point. And importantly, for short-acting methods such as the pill and condoms, this is distribution, not consumption data. So after the method is given to the woman, there's really no idea whether or not she actually goes home and takes it. There can also be timeliness issues. Getting data from all the data points within a reasonable amount of time can be a challenge. And also importantly, in most countries, the data will only be from the public sector. Women who get their family planning from the private sector may not be included. In some countries, this can be a very large segment of the population. Next slide. To give an example of some of the variations in quality of service statistics from different countries, I'm going to show data from 3 countries. I'm not going to include which country the data is from, but these are based on real data that have been collected through Track20. So in this first example, the green line represents modern contraceptive use from national surveys such as DHS or MICS. The blue or purple line, I'm not sure what color it shows up on your screen, on mine it's a very dark blue, is modern contraceptive prevalence estimated from service statistics. So in this example, the service statistics data is not bad. As you can see, the lines are relatively close together. Next slide. In the second country example, where again the green line is modern contraceptive prevalence from a survey, and the blue line is an estimated prevalence from service statistics, the data is not as close as the previous example, although there is a little bit of convergence for the two lines in the early 2000s, but still the data isn't all that far apart. Next slide. In this last country example, we see that the prevalence estimated from service statistics is very different from the prevalence from surveys. Of these three examples, this one has the biggest difference by far, indicating lower quality of the service statistics from this country. Next slide. So our challenge within Track20 is to create a tool that works for all of these examples, meaning that it works regardless of the quality of the data in each country coming through their service statistics systems. To allow for flexibility as to the type of data that a country will use in the tool, earlier I mentioned we were focusing on three types of service statistics: commodities, number of users, and number of visits. The tool needs to allow the country to use whatever data is available to them amongst those three. It also needs to be able to be updated. If there's a new national survey that's released, such as the DHS or a PMA 2020 survey, a country should be able to enter that data into the model so that all of the available data is being used to produce estimates. And importantly, it needs to be user-friendly so that countries can run the model themselves. In the beginning, it'll be done with support from Track20, but hopefully in the long run, they'll be able to run it independently. Next slide. So luckily, there's an existing model that provided a platform to get things started. The United Nations Population Division has an existing model that already produces annual estimates of 3 of the FP 2020 core indicators. And these include modern contraceptive prevalence rate, unmet need for modern contraception, and percent of demand satisfied by a modern method. So what the graph shows you in the lower left-hand corner of the slide is an example output from the UNPD model. The red circles show data points from DHS within this country, and you can also see that there are 3 lines. The middle line, which you can see flows through the center of each of the red circles, is the median MCPR. The other 2 lines, the upper and lower lines, provide the confidence intervals around that median estimate. You can see that these 3 lines are relatively close together as they move through the red circles, and then they get further apart as they are projected forward after the last cross-sectional data point. Next slide. So the model created by UNPD is a Bayesian hierarchical model that has a logistic growth curve that models the trends from low to high CPR. For those of you who are quantitatively interested, the specific formula is included. However, the important thing to take from this graph is that we know that contraceptive use increases in an S-shaped pattern. We know that growth is slow when a country has a low prevalence, that there is then a period of faster growth, and then when the country becomes high prevalence, the growth slows down again, and that's really what's represented here. Next slide. So the model then uses all of the survey data available for each country and fits that curve or that line to the real data. So this is an example of a specific country and how, although the S-shaped curve is slightly flattened, there's still a consistent pattern as contraceptive use moves from low prevalence to high prevalence. Next slide. So in reality, what the model actually does is it fits many lines. So it sees how many lines it can fit that still gives a reasonable assumption of passing through all of the available data points for that country. So it provides us with all possible options of a curve that would work for a country based on its real data. Next slide. So overall, the UN Population Division's model uses prior information about the ranges of the model parameters to determine the goodness of fit of alternative sets of parameter values. This is why all data from all countries is included in the database. All DHS mix, national surveys, and now PMA 2020 surveys are included in the model. And it uses a hierarchical fitting so that different parts of the estimates are based on country data only, and some are based on experiences around sub-regional and regional data. Next slide. So we started with this UN Pop Division model and made a few significant modifications. First, the model has been programmed so it is possible to run one country at a time. However, the prior assumptions on some of the parameters are still informed by regional and sub-regional values. So you still get the full power of the model even when just running it for one country, which is important because to run it for all the countries together takes a couple of days, would take a lot of patience. So being able to isolate a single country allows you to have a result rather quickly. Second, it's now possible to add service statistics and see how they impact the estimates. Importantly, the model is still anchored by the cross-sectional surveys, so the data from the service statistics only informs the projection past the last survey data point. So if you remember the graph we looked at earlier that showed those 3 lines projecting forward after the last DHS data point, the service statistics would let us know if we are continuing at the same trajectory or if we are tipping the line up or down. So this allows the estimates to be modified based on annual data. So this new tool is called the Family Planning Estimation Tool, or FPET. Next slide. So using FPET requires 2 steps. So the first, you need to prepare your data. So you can see the tool for this, which is on the slide, which is a downloadable app. In this case, I've selected Kenya as the country and have loaded all of the data currently included in the model's database. So the last DHS in Kenya was in 2008-2009. So that data is up to date. I would then select the Add Row option and start putting in data from service statistics. So you're able to add as many rows as possible, or you're able to include as many years of service statistic data as you have. Next slide. So once your data is ready, you can switch to the online FPET tool. You would upload the data that you just prepared, select that you would like to do a new run or start a new projection run, and then click to run the model. So the model is currently on a temporary server, but is in the process of being transferred to its permanent home. So the address that you see on the slide, if it's even possible to see with such small type, is only temporary, and the new one will be ready in about a week or 2. So next slide. So the 2 steps to run the model are pretty easy. And the model can easily be run using cross-sectional data if you don't have any service statistic data to add. However, if you do want to use service statistics, there are a few requirements. First, you have to have more than 1 year of service statistic data, and in reality, the more years the better. You also need to have at least 1 year that overlaps with a cross-sectional survey. This is important to calibrate the model. So remember that service statistics have quality issues, and the value of this model is that it can be used regardless of those issues. However, it has to understand the problems that are happening in each country. So you remember how the quality of the service statistic data varied in the 3 country examples we looked at earlier. It's important for the model to understand this, and to do that you need to enter in at least 1 year that overlaps with a cross-sectional survey. You also need to have at least 1 year of service statistic data after the last survey. Remember that the model will always use surveys as anchors, so the lines will go through the survey data points. The projected estimates are only following the last survey, so that is what you will influence with the service statistic data. So this is what will allow us to see if our line has tipped up or down. Entering service statistics only between cross-sectionals and not after the last one will not change your estimates. Next slide. So this slide is a summary slide that shows how FPET will be able to understand multiple types of data. So the example that we looked at earlier only has red circles, which represent DHS data points. However, as I mentioned earlier, the model includes all national surveys, or as many as can be found, and each of them are coded differently so that the model understands what type of data they represent. So the graphed outputs in most countries are a lot more complicated than just simple red circles, and look more like what you see here on the screen. It's not necessary to see all of them just to understand that the specific symbols relate to different data sources. So the green circles are mix, and you can see one in the top graph. The upside down black triangles are PMA 2020, and the black circles represent service statistics. And the other symbols, such as the red upside down triangle, means it was a DHS, but based on ever use instead of married use. So lots of symbols, but very important to indicate to the model what type of data you're entering, so it has an idea of how to let those estimates inform the projections. So this slide is meant to show the different variations of applications of FPET within FP 2020 countries. So the first top graph, you can see that a PMA 2020 estimate is the last survey estimate, and that the middle line, the median MCPR, goes right through that triangle. So that data is helping to drive the estimates forward. In the second, or the middle graph, shows an example that will produce annual estimates using service statistics. They are very hard to see on this slide, but there are actually tiny black circles in that graph showing multiple years of service statistics. The last graph shows the results for countries that will be just based on cross-sectionals, since neither PMA 2020 or Track20 is active in that country, meaning that the annual estimates will not be modified by nationally produced data. So then to the right of the slide, you can see how all these results will be pulled together and will be summed from all the countries to be able to see progress towards the 120 million additional users by 2020, which is the overall objective of FP 2020. Next slide. So this is my last slide, and just to close, I want to give credit to those who created these models. So we have methods that are created by Leontino Kema from the UNPD, for the UNPD model, and the adaptations done for FPET and programming in R were done by Jinru Nu. And an advantage that I didn't touch on, but which has received a lot of positive feedback from countries, is that the model can be applied at the sub-national level. So estimates of MCPR can be monitored and low-performing areas can be identified. So they don't all have to be national estimates. They can be broken down to lower levels within a country. And as with all models, it'll be constantly updated as new data becomes available. And as the model learns more about service statistics, our estimates will become more and more accurate. Thank you.
Thank you very much, Emily. I'm wondering how far the model has gone into countries at this point.
So we are just in the process of doing our first round of applications. So last week it was used in Cote d'Ivoire. This week it's used in Pakistan. A couple weeks ago it was used in Malawi and Ethiopia. Next week it'll be used in Rwanda. So just sort of in the middle of doing its first application across as many of those 23 countries as possible.
Great. And who carries the data to the policymakers?
So the consensus meetings that are happening in the countries are hosted by the government and has the policymakers there, including donors and partners. So the data in most countries has been prepared and analyzed and run through the model by M&E officers that are supported by Track20. And then during the day of the consensus meeting, that information is shared, the methodologies are discussed, and the information is handed over at that time to the decision makers, and then a plan for dissemination would be sort of taken from there.
Great, thank you very much. At this point, we're taking questions from participants, viewers. The first one is a question for Scott. How do you randomly select the households that the enumerators interview, and how do you ensure that enumerators adhere to this selection of households? Are any back checks or other Q&A performed? This is from Doug Johnson at Shops.
Yeah, okay, great. Yeah, so we, in a given enumeration area, a first step is doing a mapping and listing of all households in the enumeration area. These generally number around 200 households, the enumeration area. So the first step is for the enumerator with assistance from her supervisor to map and list all households. and then we use a random number generator to select a starting point from a listed set of 200 or so households to select the first one, and then it's a numeric skip pattern after that. Yeah, and then in terms of quality checking or validity checking, we have a 10% check that the supervisor does of the households to be sure that the interview took place, and that'll be an opportunity to see that the household was the one that was selected as well. We monitor. One of the things we do by taking the GPS readings for each household is that we can see that the enumerators are actually moving around a community to collect their data and submit it. So we have various ways of checking the validity of the data.
Great, thank you. The next question is from Idrisi Huili. He says, I work several years in Ouagadougou's Demographic and Health Survey at ISSP, and we have a good experience in data collection with smartphones. But in addition to good programming, one of the problems with the smartphone is its energetics autonomy. How do you deal with this, mainly in rural areas?
Okay. I'm not sure what's meant by, did you say energetics?
Yes, energetics autonomy.
I'm not sure what that what that means. Maybe the questioner could.
Yeah, maybe they can write in with a clarification.
One thing that I will say is that one of the advantages of the smartphone today is that, as I mentioned at the outset, is it can store the data. So there could be communities where there's not a cell phone connectivity in that community. So when the interview is completed, the form can't be submitted to the cloud server, but it can be saved. So we ask that the form be saved then. Another interview can be done. The next household, that can be saved. A whole day's worth of interviews can take place and saved. And then the enumerator will move to a hotspot and then load the data up. So maybe that's not what energetics autonomy is, but just to
that's helpful.
Possibly is what was meant.
Thank you. The next question is, are all women in selected households included? Some data presented said married women, and what are the criteria for who responds?
Yeah, so we start each interview with a household roster to identify who's in the household and characteristics of the household, and we use that then to select the eligible females to be interviewed, and we'll interview all females in the household, whether they're married or not, age 15 to 49. That's similar. That's exactly what DHS does.
Emily, do you do the same, or you're not dealing with that?
She's not dealing with data collection.
Okay.
No, but service statistics inherently would be from all users in most cases. So when we're looking at the number of users or the number of visits, most likely it pertains to all women and not just married.
Aha. The next question is, how does data feed back into the community and how is it received?
Yeah, so at the moment we're just beginning to do that, the feedback. We hold a national dissemination seminar, which we've done in 3 countries now that have completed their data collection. And we've asked the supervisors to share the data back at the regional and district levels. We've equipped them with a tablet, which allows them both to conduct the interviews themselves, as they do with as I mentioned, with the public sector facilities. But the tablet then also allows them to present the data in graphic, both in table and graphic forms, easier than on a cell phone. So we're pushing the data out that way through the supervisor network. We do refresher trainings with our enumerators between each survey, and we're giving them information about the results of the survey to share back to their communities. We're still working out ways in which we can push the data through the smartphone to have some data presentations that they can show at the community level. That's still in the works.
Mm-hmm. Thank you. Any other questions from listeners?
Yeah, just one general question. This is Mark Mather from PRB. These are obviously innovative projects, and so I wondered if there were any unexpected findings or particular challenges that you hadn't envisioned when you first started on these projects.
So maybe I'll say a few things. One that I mentioned before is finding a cell phone that meets our criteria. It hasn't been as easy as we thought it would be. They have to be an Android phone with a certain level of operating system. They have to have the various features that I mentioned, which many of them have, but the GPS is where many of them fail. So for our first 5 countries, we've used the same cell phone. It's an Alcatel 5020D, and that's actually worked well for us. We're still looking for other phones that we can use in other instances.
So I can add from our perspective, the one sort of surprising thing that we found is that it's very difficult to get multiple years of service statistic data, specifically in countries that have recently transferred from a paper to an electronic system. So it seems that countries don't really have an active plan to enter in that old data to their system, and it sort of becomes lost once they start just entering in electronic. So although that's very helpful moving forward, there seems to be a bit of a lack of collation of the data from the old system.
Okay. One more question that just came in. Scott, you mentioned starting with a focused set of questions. Is there a timeline for considering adding additional modules or questions related to family planning or broader issues?
Yeah. So every time I made a presentation to various audiences, there's always ideas on additional questions that could be added or additional modules. And so we've been fairly clear that we want to maintain a consistent set of questions in both our facility and our household and female surveys for the first year or so, and then to entertain any modifications or additions. So we're kind of reaching that point now where we may be making a few modifications. And one that I might mention is that we have been reporting thus far on the percent of facilities that have had a stock out in the past year, and we're thinking of supplementing that. Two things. One is that there's a view that 1 year may be a difficult time for a recall, so there could be some error introduced there. So we're going to be relying on percent of facilities that are out of stock on the day of the visit, where it can be actually validated by the enumerator visually. But then supplementing that with a question on duration. So how long has this method been stocked out? And we get then a duration, which we don't currently collect. We might use that in combination with a recall, maybe over a shorter interval, 3 to 6 months perhaps.
Okay. A quick follow-up question from someone. How long does the current survey take?
Yeah, so the survey is designed to be implemented in a 4 to 6 week period. For the first round, there's a few weeks that are required, a couple of weeks at least, for doing the mapping and listing before the data collection can begin. But we've been fairly close in each country to completing it in a 6, sometimes to 8 week period. So we think with additional practice that we can get the survey turned around even more quickly. And then, of course, the enumerators are activated for about a 2-month period, and then are lax for a few months, and then we reactivate them for another two months. So there are intervals of time that could be taken up by additional modules. That's something we're looking at, is introducing potentially additional modules to the platform.
And I think that actually what they were referring to is how long does it take for the respondent to answer the.
Oh, I'm sorry. Yeah. Okay. Yeah. So you may have seen in the in one of my earlier slides there are about 50 questions in the female survey and about 50 in the facility survey. It depends upon your answers to certain questions, how long it takes, because we have these skip patterns. So if you've never used contraception, the survey could be very short. But on average, the interview time for the female survey is about between 15 minutes to a half an hour. And for the facility survey, again, it depends on the size of the facility and the volume of work that the facility takes on around family planning, but that can also take maybe between 15 minutes and a half an hour, perhaps a little bit more.
Okay. Emily, question for you. Someone said, great presentation. Do you think that the quality of the service statistics data will improve due to the increased use of these data? And have you seen increased attention to the quality of service statistics at the country level, or is it too soon to say?
Yeah, so we're certainly hoping that it sort of draws attention to the need for improvement. So it's too early to say if that's actually going to work. But what I can say is that the initial discussion and the process of these countries needing to actually collect the information has really led to some really interesting and helpful conversations around that. And one of the key points that we talk about in this first year as we're applying the model for the first time is what steps do we need to focus on this upcoming year to get ready to do this same process next year, and how can we make sure that we have more data and better data throughout the process. So it's a hope, but a bit too early to know if it actually pulls out in the end.
Scott, two questions came in related to each other for you. One, do you have to work with mobile service providers in the respective countries, and if so, what challenges have you encountered with them? And then two people asked whether respondents are compensated for their time.
Yeah. I'm sorry, whether the enumerators are compensated?
Whether I think the respondents are compensated.
Okay. Yeah, that varies by country. Sometimes there's a small gift that's given, and in some countries they're actually sticking with the mobile technology theme. They're giving airtime. Many people have phones and value the airtime that they can be given, so that's happened sometimes. Our enumerators, I should add, just for those who are wondering, are compensated for doing a round of the survey. It varies by country a bit, but something in the $200 to $400 range, I guess, per round. Let's see. Sorry, the other question was
related to challenges in working with the service providers.
Mobile providers, yeah. So so in some countries there's a dominant service provider that we work through, but in many countries there are multiple providers, and in certain parts of the country there's better access to some providers than others. So that's been sort of a challenge to figure out which provider in which region we should be connecting with. One of the things we like about the phone that we've selected, the Alcatel 5020D, is that it has 2 SIM slots, so we can actually put we can actually connect to 2 providers without flipping those around. And some places that becomes very valuable. We've talked to some mobile providers to provide to help us support certain needs. And in Kenya, for instance, there's a way that we're exploring that can ensure that our enumerators don't run out of airtime in a very effective way, rather than having them sort of deal with the problems one-off. We can sort of share the airtime as a family, in a family plan.
Okay.
Okay, and this might be our last question we have time for today. Someone cites the problems in the U.S. Census and 2010 Census with handheld computers in the field, Southeast Indiana, and they're wondering if these countries are actually better supplied with the cell towers needed for this kind of work.
I'm sorry, are they better supported than in the U.S.?
Well, I guess in certain rural areas there may be some issues with cell phone coverage, and it sounds like you've had some success in.
Yeah. So cell phone. Maybe I should say a few things about that. The cell phone coverage we found quite good in most parts of most countries. There are exceptions. I think on one of my slides I pointed out that in DR Congo, the survey is limited at the moment to the capital city of Kinshasa. And that's because the cell reach isn't very good beyond the urban areas. We're planning to fan out to encompass some additional cities in the DR Congo over time, but we probably won't go national within the time frame of this project.
Okay. Well, Susan, Scott, Emily, does anybody have any final comments or?
Nope, just happy that this all worked out. The technology worked even though we're in different continents. So thank you, Mark and Susan, for making this happen.
Yes, thank you for sharing your work. It's pioneering, and we look forward to the results.
Yeah, I want to thank everyone, Susan, Scott, and Emily, again for taking the time to present in today's webinar. It's an important topic, and I think we'll be hearing more about it as Scott and Emily collect more data in the coming months. So again, I want to encourage people to fill out the brief survey that you'll get at the close of this webinar, and we hope to see you in future webinars. Thanks very much. This concludes today's presentation.